Today we're going to be talking about the challenges to physical health, and this is found in Chapter 8 of your book. The objectives that we want to cover, we want to describe what an atypical presentation is and how an older adult may present with an atypical presentation. We want to discuss the lifestyle modifications, including changes in diet and physical activity, that may be helpful in treating or preventing these common conditions. And we'd like to understand the ways in which these conditions are treated, the goals of drug therapy, and any important cautions associated with drug use. Atypical presentation are most common in people over age 85, those with multiple comorbidities, taking multiple medications, and those with impaired cognitive status or functional impairment. Common conditions associated with atypical presentations include infections, falls, urinary incontinence, myocardial infarction, and congestive heart failure. Other conditions that may present in an atypical manner include silent malignancy, silent acute abdomen, depression, and thyroid disease. In older adults, infections often appear quite different than they do in children. For young people, hallmarks of infection include a high fever, swollen lymph nodes, increased white blood cell count, but in the older adult, all of these signs may be diminished or even just absent. So when evaluating fever in an older adult, it's important to note the deviation from baseline rather than the number itself, because older adults often have baseline temperatures below 98.6 degrees Fahrenheit. Instead of more common signs and symptoms, older adults with new onset of infections may present with an acute change in mental status. In fact, delirium may occur in 50% of older adults with infection. Decreased oral intake, leading to weight loss and dehydration, should be evaluated as a potential sign of an underlying infection. Acute changes in functional status and falls may also mask infection. Changes in respiratory status, such as increase in respiratory rate or a decrease in oxygenation, can indicate a respiratory infection. Falls are common in older adults and are a leading cause of disability and death. They may also indicate underlying disease. In fact, in about 10% of cases, the fall may be the only symptom of an underlying acute illness. Therefore, whenever an older adult falls, the cause of the fall should be determined. Never assume that it is normal for an older adult to fall. A variety of acute and chronic conditions can increase the risk of falls among older adults. By far, the greatest risk factor for future falls is a history of falls. Urinary incontinence is not a normal part of aging. There are several different types of urinary incontinence. Stress is the most common, and this occurs when the pressure is increased in the abdominal cavity by such activities as coughing, sneezing, or maybe lifting a heavy object. Urge is the abrupt onset of an intense urge to urinate, followed by an uncontrollable loss of urine. Overflow is more common in men with BPH or prostate cancer. The enlarged prostate obstructs the flow of urine from the bladder, causing the bladder to overfill and eventually overflow. Functional incontinence is not bladder related at all. An example would be that the person gets up to go to the bathroom, they have arthritis, and they're not able to walk to the bathroom and get there in time to urinate. Or either there's something in the way, the path from the bed or the chair to the bathroom, and they simply don't have time to get to the bathroom. Urinary tract infections go undiagnosed because there may be an absence of dysuria or painful urination, and also absence of leukocytosis. Older adults' susceptibility to all infections are due to the suppressed immune system that comes with aging. Elderly men and women experience a weakening of the muscles of the bladder, which leads to more urine being retained in the bladder, poor bladder emptying, and incontinence, which can lead to urinary tract infections. And if these go untreated, they can lead to urosepsis. Cardiovascular disease is the leading cause of death in the United States. 27% of all deaths nationwide. It is also the leading cause of death for people over 60 years of age. It is not an inevitable consequence of aging. MIs, stroke, hypertension, peripheral artery disease, and heart failure are all caused by diseased blood vessels, which interrupt the flow of oxygenated blood to the vital organs. Cardiovascular disease increased risk include hypertension, high cholesterol, especially high low density lipoprotein, which LDL, which is the good, um, no, which is the bad cholesterol, excuse me. LDL is the bad cholesterol. Also, smoking, obesity, lack of physical activity. So, to reduce the risk of cardiovascular disease for our patients, we want to make sure that their blood pressure stay between 120 over 80. That's a good number to keep it. The bad cholesterol is less than 160. The HDL, which is the good cholesterol, is just as important for the good cholesterol to be within the limits as it is for the bad cholesterol to be within limits. So for the good, we want it to be greater than 40 for men and greater than 50 for women. Your triglyceride levels should be less than 150. Also, we can educate our clients on diets rich in fruits, vegetables, fiber, and low in sodium and low in saturated fats. More women than men die of heart disease every year. It's the number one killer of women over age 25. 1 in 29 women die of breast cancer. 1 in 2 women will die of heart disease. Older adults do not experience MIs with the classic symptom of crushing chest pain. Syncope, stroke, and acute confusion are most typically experienced by the older adults. They also may have some sweating, fatigue, dizziness, and shaking, and this can also be mistaken as hypoglycemia instead of an MI. Early diagnosis and treatment is critical to stop the progression of irreversible cardiac damage. Congestive heart failure results from several other common health problems, such as hypertension, MI, myocarditis. They may present with fatigue, of shortness of breath. In a person with high blood pressure, the heart pumps against the increased pressure. Eventually, this increased workload causes the left ventricle to enlarge and stiffen. Early warning signs of cancer may be incorrectly attributed to simply just getting old. The lifetime risk of developing cancer is higher in women higher in men than in women. Lung cancer is the most common cancer in both men and women older than age 60. In women ages 60 to 79, the second and third ranked fatal cancers in women are breast cancer and colorectal. In men, colorectal and prostate cancer. Cancer-related disease mortality declines after age 85. Constipation can be diagnosed instead of colon cancer. Arthritis might be diagnosed rather than a bone metastasis from a malignancy. Classic symptoms for all ages for diabetes include polyuria, polydipsia, and polyphagia. The presentation of diabetes in an older adult may differ from that in younger people. They may include confusion, weight loss, prolonged healing, and may also be misdiagnosed. I want you to look in your book on page 136 and review box 8.4 for your hypoglycemia symptoms and treatments. It might benefit you to look over those. Diabetes is the leading cause of blindness, chronic renal failure, and loss of lower extremities due to the destruction of these small, delicate vessels. The reason for these disorders of the vasculature has to do with the long-term effects of glucose on the blood vessels, increased formation of plaque, clots, and inflammation. Macrovascular disease is a disease of any large blood vessel in the body. It is a disease of the large vessels, including the coronary artery, cerebrovascular, and peripheral vascular disease. Your small vessel disease is sometimes called coronary microvascular disease or small vessel heart disease, and this affects your eyes, your kidneys, and your nerves. Osteoarthritis is the most common form of arthritis. Weight and repetitive use causes the cartilage between the joints to break down more quickly. So lifestyle modifications would be weight loss for the client and non-weight bearing exercises. And an example of that would be swimming. Treatments for osteoarthritis include cold packs, taking oral glucosamine, topical rubs containing capsaicin, and acetaminophen. NSAIDs such as ibuprofen and naproxen are effective or even more effective, but because of the gastrointestinal bleeding, it's not highly recommended for these clients to stay on ibuprofen or naproxen for very long. Corticosteroids are injections that can be given to the client into the joint, and it can reduce pain and inflammation. It's a temporary fix. It might last 3 months. It might last 6 months. It's possible it could last up to 12 months, but it's just a temporary fix. Visco supplementation is where you inject a cushioning fluid between the bones, and this also will reduce pain, but again, it's a temporary fix. It's not going to cure the osteoarthritis, but it will relieve pain for a while. Osteoporosis is the reduction in bone strength and density that can increase the risk of fracture. Type 1 would occur in women between ages 51 and 75, and this results from loss of estrogen following menopause. Type 2 occurs after age 70 in both men and women, and it's caused because of reduced vitamin D synthesis and disuse, or just not using um, those limbs. Osteoporosis increases the risk for falls, and women are a greater risk than men. DEXA scan is the most common way to check for osteoporosis. And we just talked about women between ages of 51 and 75 develop osteoporosis as a result of loss of estrogen following menopause. Well, estrogen is essential for calcium to be absorbed and deposited in the bones. With postmenopausal women, this can be a problem. The risk of heart disease and cancer outweighs the use of supplemental estrogen. So we're not recommending um, estrogen as a fix for osteoporosis. Bisphosphonates is the main drug used to treat osteoporosis, and it works by inhibiting the activity of the osteoclast, and it helps prevent bone loss and can help build up and strengthen existing bone. It's very important to know if your patient is taking this drug to treat osteoporosis. Uh, it's extremely irritating to the gastroesophageal tract. Therefore, the patient should be instructed to take it with a full glass of water, and the patient should remain upright for 30 minutes. Your responsibility as a nurse is to assess the patient's ability to tolerate this much fluid and also the ability to remain sitting up before we decide to give them these drugs. You can strengthen the bones through dietary, for instance, calcium. You can suggest your patient drink lots of milk, cheese, yogurt, collard greens, and sardines. Also, you can strengthen those bones through exercise, walking, hiking, dancing, weightlifting. Chronic obstructive pulmonary disease, or COPD, impairs the movement of air through the lungs. There are two types. You have your chronic bronchitis, and then you have your emphysema. Your chronic bronchitis airways are inflamed, and excessive amounts of mucus is formed. Emphysema, the alveolar membranes break down. As you can see in the pictures, here's where all the mucus is forming, and you can see the healthy alveolar, and over here is where it's breaking down, so it's not healthy anymore. Cigarette smoking is by far the most common cause of chronic bronchitis. The airways of people with chronic bronchitis may also have been irritated initially by bacterial or viral infections. People exposed to industrial dust and fumes in the workplace, such as coal miners, grain handlers, metal molders, are also at a high risk of developing this disease. Air pollution can also worsen the chronic bronchitis symptoms. Emphysema is the main type of chronic obstructive pulmonary disease, and also, although it has no cure, quit smoking reduces the rate of emphysema disease progression. So, encouraging them for smoking cessation is going to help. It's not going to um, cure them, but it will certainly reduce the rate of the progression of the disease. I know. Shortness of breath with exertion is the cardinal symptom of COPD. The inability of the lungs to fully retract when inspiration leads to enlargement of the lung tissue, causing outward pressure on the rib cage, leading to the development of a barrel chest. And if you've ever seen someone with a barrel chest, you'll not forget it. It looks just like a barrel under their t-shirt. They can have difficulty or painful breathing except in an erect sitting or standing position. Also, it's known as orthopnea. The picture is a very good picture showing how he has to lean forward almost in a tripod so he can breathe. Also, we recommend pursed lip breathing, and that's when you breathe in, inhale slowly through your nose, count to 2, pucker your lips if you were going to whistle or blow out a candle. Breathe out, exhale slowly through your lips for 4 or more counts. You want to exhale normally. Do not force the air out. Do not hold your breath when you're doing pursed lip breathing. And you can repeat these steps until your breathing slows. For nutrition, page 140, see box 8.5 and 8.5, and just read over that box and be acquainted with what is in that box. Page 140, box 8.5. As far as your physical activity, you want to tell that patient they must remain physically active. Yoga is a very good exercise that they could do. Um, it's not very strenuous. Um, Also, physical activity helps prevent some of the comorbidities associated with COPD, such as depression, osteoporosis, diabetes. Drug therapy for COPD. The goal is to reduce inflammation and open the airways to improve movement of air through the lung. Patient can use a multi-dose inhalers. They can get nebulizer treatments, and they are at high risk for pulmonary diseases and infections. So, to help prevent these pulmonary diseases and infections, we want to ensure that that patient receives vaccinations for seasonal flu, pneumococcal pneumonia, antibiotic therapy, and ventilator therapy. So these are some education pieces that you would want to do with your patient that has COPD. And also for the patient with COPD, end of life um, symptom management. They're going to have shortness of breath, possibly, anxiety. You can imagine if you're trying to breathe and you can't get the air in or out of your lungs, how anxious that would make you. Um, and then, of course, pain. Sublingual opioids in combination with anti-anxiety drugs should be titrated in response to frequent nursing assessments. Also, some other therapies that you might try is to have fans. Now, if you're utilizing a fan in the hospital setting, you must get an order for a physician. You can't just tell the family members, go home and bring a fan, or no, go to the supply room and get one. You must have an order from the physician to use a fan in the patient's room. Fresh air would be great. So if the patient's at home or in a nursing home or assisted living, you could tell them to, go sit out on the deck or open the windows up. In the hospital, you wouldn't be able to open the window, but if family members are there or have a tech that could push them out to um, a non-smoking area at the hospital so they could get some fresh air. Also, massage is another therapy that would help the patient with COPD. Remember that older adults often have baseline temperatures below 98.7, so look at their baseline to determine if they are febrile. I just made this chart for you. I want you just to kind of review over this chart. It gives you the illness on one side and then the atypical presentation on the other. Infectious diseases, for instance, may be absence of fever. They can even be septic and still not be febrile. Um, they can have falls, decreased appetite or fluid intake, confusion, change in functional status. I think we reviewed most of this at the beginning of the slide, but I just put it in a table for you so it would be easier for you to study. The silent malignancy, back pain secondary to metastasis from slow-growing breast masses, or they could have a silent masses of the bowel, silent acute abdomen, absence of symptoms. They may have mild discomfort, they may have a little constipation, tachypnea, or just no symptoms at all. Depression, lack of sadness. Somatic complaints such as appetite changes, vague GI symptoms, constipation, sleep disturbance, or just hyperactivity. And then your thyroid disease. Hyperthyroidism presents with fatigue and a slowing down instead of the classic thin hyperactive person or hyperactive patient. It's just the opposite of what you would expect. Hypothyroidism presents with confusion and agitation instead of fatigue and weight gain. So this again is just the opposite of what you would expect with someone that has hyper or hypothyroidism. That concludes our lecture. So just look over these tables, and I will see you next week. Thank you very much.